Hello, welcome. I hope you had a good lunch. We'd like to commence our final session for today. The session will be talking about embryology in general. I would like to call upon to the stage the chairman, Professor Ralph Henkel, Dr. Liam Marie, and Dr. Salwa At-Twil. Could you all join me to the stage, please? Our first keynote speaker for this session will be Dr. Intisar Al-Muntasir from Dubai. She has a master's degree in assisted reproductive medicine and embryology. She was one of the first embryologists in Libya. She currently works at the Health Plus Fertility Center. She also enrolled in a PhD program in South Africa. Her topic today will be about frozen embryo transfer versus fresh embryo transfer. Stage is all yours, Doctor.
Bismillah ar-Rahman ar-Rahim. Thank you very much to introduce me to the audience. I will be talking about frozen embryo transfer as a new strategy versus embryo transfer. Over the last decade, the use of frozen embryo transfer, FET cycle, has been dramatically increased to a report of Society of Assisted Reproductive Technology. The number of FET cycles increased up to 82.5% between 2006 and 2012 than fresh embryo transfer cycles. The increase up to 32.4% in the last European survey, which was a significant increase compared to the previous one. However, the main reasons underlying increased trend FET cycles are threefold in the last few decades. Firstly, a new technology has become the dominant method used for embryo cryopreservation with high survival rate, thanks for vitrification technique. Secondly, a rapid rise in singleton embryo transfer combined with a pre-implantation genetic screening with the increase of high number of normal embryos to be frozen. Thirdly, large number of studies had demonstrated that FET may lead to favorable parental and neonatal outcome. Did I miss something? Okay. The first live birth from frozen embryo was in 1984. The use of freezing was only to freeze the surplus embryos in the current cycle to utilize them in the future. Nowadays, it became the best option when fresh ET is not applicable in the cases of ovarian hyperstimulation syndrome, suboptimal endometrium on the day of a fresh ET, and alteration in endometrium receptivity in a fresh cycle, a premature evaluation of progesterone. So vitrification is no longer considered as an experimental technique. It's a well-established procedure. The breakthrough of vitrification changed trends towards freeze-all option. What I'm doing. Yeah. So fresh embryo transfer versus frozen embryo transfer has been a point of hot debate and cool procedure almost all in IVF practice at the same point. Why? Evidence-based medicine, individual clinic KPIs, and the future of IVF. Is a freeze-all strategy in IVF ICSI treatment safe and effective in comparing to conventional IVF ICSI treatment? Conventionally, IVF treatment consists of a fresh embryo transfer directly after ovarian stimulation and in order of egg retrieval and in IVF ICSI procedure. In the conventional IVF ICSI treatment, fresh embryo transfer is possible, followed by freeze the surplus to use them in the future. Alternatively, cryopreservation provides an alternative approach that decreases the risk of severe hyperstimulation syndrome. In the absence of an effective clinical tool to evaluate endometrium receptivity, non-invasive one, the ERA test, which is embryo and endometrium interaction. ERA test is applicable only in frozen embryo transfer, but it's invisible in fresh embryo transfer. In the case of pre-evaluation of serum progesterone concentration, and we know that the increase of B4 related to decreases pregnancy rate in fresh cycle. So freeze-all strategy is the alternative method. Many evidences supported that controlled ovarian stimulation with its sober physiological hormonal intake may decreases the endometrium receptivity. Moreover, endometrial development can be more controlled in FET cycle. The thickness of the endometrium, why we need to focus only on millimeters instead of shift our focus towards to improve IVF outcome with emphasizing of singleton embryo transfer, endometrial preparation protocol with hormonal replacement cycle that results healthiest pregnancies. The impact of cost effectiveness on both fresh embryo transfer and frozen embryo transfer. Most of IVF centers overall the world advocate a single embryo transfer than transfer multiple of embryos. Hence, in such a strategy which taught to reduce costs of both obstetric and neonatal care while improving neonatal outcome and relatively high of implantation rate. In the case of repeated IVF stimulation cycle, patient has to go through oocytes retrieval and an ICSI IVF procedure, embryo culture, with or without pre-implantation genetic testing, and then followed by a fresh ET. Every single step with this cycle has to be paid. In fact, the cost of frozen embryo transfer is approximately 1/4 of those associated with repeated IVF cycle. Vitrification. A freezing success rate continue to improve thanks for vitrification procedure, which is welcome progress with a great encouraging for patients who have surplus embryos to freeze and freeze all strategy in their interest. Vitrification is a technique allows preservation of embryos rapidly in liquid nitrogen at a temperature -196 Celsius within seconds. High implantation potential by single embryo transfer. Why? Due to very high survival rate on comparing with slow freezing. Vitrification is an efficient and safe procedure with long-term management. Vitrification allows the gap between fresh embryo transfer and frozen embryo transfer outcome is too close. Indications based on randomized controlled trials proposed as rescue strategy to improve safety and enhance live birth rate, or as a scheduled strategy based on patient characteristics to ensure better condition for embryo transfer and to limit the adverse effect of ovarian stimulation. And scheduled strategy, before the patient has to start her medication, in the case of pre-implantation genetic testing, either day 5 or 6 through ectoderm biopsy, all embryos have to be frozen to use them in future for FET cycle. In the case of adenomyosis or endometriosis, repeated IVF cycle failure, or to avoid the risk of thromboembolic disease. And the rescue strategy in the case of severe hyperstimulation syndrome and polycystic ovary. If any anomalies in the uterus or in the tubes, and in the evaluation of progesterone at the trigger. In the embryological reason, if the embryos did not meet, development of the embryos did not meet the synchrony of the endometrium, so it's better to freeze the embryos and use them in the future. Safety, we know that ovarian hyperstimulation syndrome is the main major risk in IVF field. It could be lethal. To avoid a fresh transfer can be dramatically reduce the chance of moderate and severe hyperstimulation syndrome. In obstetric outcome and FET cycles associated to reduce a chance of ectopic pregnancy, early miscarriage, and placenta previa. FET cycles also associated with hypertensive disorder in pregnancy due to the artificial method to prepare the endometrium. Neonatal outcome, fresh ET associated with low risk of preterm delivery, small of gestational age, and low baby weight. FETs associated with large of gestational age. No differences between FET and fresh ET in neonatal ICU admission, prenatal mortality, or congenital abnormalities. Efficacy, I'm gonna explain the cons and pros for between fresh ET and frozen ET based on meta-analysis around 54 studies and RCT around 12 by Young in 2020 to compare the pregnancy outcome, maternal complications, and neonatal outcomes between fresh and frozen embryo transfer, blastocyst transfer. In fresh embryo transfer, the disadvantages are low implantation rate, low in pregnancy rate, low in going pregnancy rate, low in clinical pregnancy rate, and high in ectopic pregnancy, high risk of moderate or severe hyperstimulation syndrome, high in placenta abruption, high in placenta previa, and high in preterm delivery. The advantages of a fresh transfer, low in preeclampsia, low in pregnancy-induced hypertension, small of gestational age, and low baby weight. In frozen embryo transfer, the advantages are high in implantation rate, pregnancy rate, ingoing pregnancy rate, clinical pregnancy rate, and cumulative birth rate, and low in ectopic pregnancy, low risk of moderate and severe hyperstimulation syndrome, low in placenta previa, and low in placenta preterm delivery. But the disadvantages of frozen embryo transfer, high in BIH, and high in pre-eclampsia, high for gestational age, and high baby weight. Treatment and protocols for FET, I'm gonna explain in this slide. Cycle regimens for FET, frozen and thawed FET, or frozen or thawed embryo transfer by Tariq Gubara in 2019 in reproductive medicine in UK. He used standard methodological procedure recommended by Cochrane. He included around 18 RCT comparing different cycle regimens for FET to compare the effectiveness and safety of natural cycle for FET, hormonal therapy cycle for FET, and ovulation cycle for FET, and compare the subtype of these regimens. In the natural cycle, dominant follicle will produce E2 and to maintain the thickness of the endometrium. Ovulation will take place and the follicle became corpus luteum, which produces the progesterone to maintain the endometrium and enhance the implantation. The advantages of natural cycle, no medication has to be taken, and preferably for many patients, and this cycle is only applicable for patient who has ovulation, regular ovulation. The disadvantages of natural cycle required many pelvic ultrasound to detect the ovulation and blood test to detect the LH surge. Cancellation rate is high. To avoid this, ovulation induction can be administrative. Modified natural cycle, ovulation has to be triggered by HCG instead of spontaneous LH surge. Luteal phase can be supported by B4, it's an option. Ovulation induction, FSH, triggered by HCG, luteal phase has to be supported with progesterone. Fourth, hormonal replacement cycle, oxygenous E2 and B4 to improve the endometrium to enhance the implantation. Hormonal therapy cycle with the suppression of GnRH, oxygenous E2 and B4 to improve the endometrium. So both are hormonal replacement therapy with or without suppression of GnRH has no corpus luteum. The advantages of hormonal therapy cycle, high level of control and flexibility in the timing of transfer. Cancellation rate is too low. If the pregnancy occurs, E2 and B4 must be continued until a placenta anatomy is established to replace the absence of corpus luteum. The only disadvantage in both cycle is expensive. So in this review, he didn't find sufficient evidences to support the use of any cycle regimen, but he found out that the most common modulites of FET are natural cycle with or without trigger by HCG, or hormonal therapy cycle with or without the suppression of GnRH. But hormonal therapy cycle is alone associated with low live birth rate than the one with the suppression of GnRH. There is no differences in terms of pregnancy and delivery rate, and the most common regimens for FET are natural cycle with or without HCG, or hormonal replacement cycle with the suppression of GnRH. In this slide, I'm gonna share with you our statistics. In 2019, our total count shows in a blue color, biochemical pregnancy in yellow color, and clinical pregnancy in green color, if you can't see the color clearly. So total count in 2018, above 600, biochemical pregnancy 52%, a clinical pregnancy 40%. In 2019, our total count greater than 700 biochemical pregnancy dramatically increased 60%, clinical pregnancy as well a bit increased comparing with last year. In 2020, if you see this graph or chart, you will be a bit surprised because of the pandemic, coronavirus pandemic in the year. If you can see in January, we have 0 ET, fresh ET or 0 FET. All our cases were frozen, and in April, due to the lockdown in the country, we were forced to take corona leave, so we have 0 cases. In May, we have around less than 10 cases, but still our clinical and chemical pregnancy is okay comparing with the count, and dramatically increase in June till end of the year. In conclusion, embryo freezing is highly successful and well-established technology. It's a safe and efficient way to reduce ovarian hyperstimulation risks. A freeze-all for all policy is a practice in almost IVF centers over all the world. A freeze-all leads to high live birth rate in high responder and normal responder with evaluation of progesterone. Obstetric and neonatal outcome are greatly better than freeze-all cycle comparing in fresh cycle. Cost can be managed and reduced since we are freezing the surplus of the embryos in the current cycle and use them in the future. A frozen embryo transfer or freeze-all strategy will not be developed if it doesn't have many advantages that would result to successful IVF-XC cycles, given the point I discussed later. So, last but not least, let's ask ourselves, why not to adopt a safe and highly successful strategy that allow more flexibility and have more potential to increase efficacy, eliminate ovarian hyperstimulation syndrome, reduce cost, and make treatments easier for our patient. If we are not confident with FETs or freeze-all strategy, why not to go for fresh for all? Thank you very much.
Thank you. That was Dr. Intisar Al-Muntasir. Thank you for your intriguing presentation. Now we will move on to Dr. Anfal Al-Saghir, also from Dubai. She has graduated with honors from Medical Labs Analysis in the UAE. She's continuing her master's degree in Leeds University in the field of embryology. The stage is yours. She'll be talking about quality control for embryology and andrology. Thank you. Yeah.
Hello everyone. Before I start, I would just like to thank الحياة conference for giving me this opportunity today to be able to come and present my presentation. About the topic that I'm going to explain today, it's actually one of the bases for each and every lab and every clinic that needs to be done, which is quality control. To start with, what is quality control exactly? It is a process of meeting the needs and expectations of patients and healthcare services, as well as the degree to which care services influence the probability of optimum patient's outcome. A question to ask is quality control system optional? The simplest answer is no, it's not optional, it's a must. Quality control is required by many regulators and licensing authorities as well as accreditation organizations. It is now seen more as fitness for use with the focus on patients, perception and opinion. Hence, we have quality control equals conference to patient requirements. Indicators and benchmarks. How do we know if and when a process is in control? By indicators. Indicators are objective measures for evaluating critical healthcare domains, and it is a universal tool to help you manage your business, clinic, and lab. The keynote of quality is a blastocyte utilization rate, which equals the percentage of 2P in embryo that are either transferred or cryostored on day 5 and day 6 of culture. How to achieve this? There are 3 ways, which are patient safety, effectiveness, timeness, and efficiency. Sorry for the typo. There are laboratory key points which include that we all are working in a cycle to have the patient pleased at the end. The cycle contains the patient, the reception physician, nurse, IVF lab that takes out results, and the circle goes back again. In the IVF lab, we also have the embryologists, lab equipment, and quality controls. To add for that as well, we have human resources, laboratory facilities, and quality controls. We're going to discuss in details about these points. In human resources, first of all, we have to obtain the ratio between how many cycles is the lab or the clinic is willing to have each year and the number of embryologists and technicians that can give out this number. For example, if you're looking for 2,000 cycles per year, then you're going to need about 6 embryologists and 10 technicians to achieve that number. And if you're looking at 1,035 cycles a year, then you're looking at 6 embryologists and 8 technicians needed. And for 800 cycles a year, you're going to need 5 embryologists and 6 technicians. Having a quality control in the lab can make you have enough time for each cycle, concentration, and responsibility for each and every cycle performed. The lab facilities, we have laminar flow hoods, the microscopes, incubators, and cryopreservation tanks. These are the basics for each lab. That's a must. As you can see here, we have the flow hoods, the incubators, the ICSI machine, and the liquid nitrogen tanks. As well as we have lab document control, which is which purpose is to enforce controlled processes and practices issues, distribution and accessibility of all documents, such as Meditex. Traceability is the quality of having an origin or source of development that We could find and verify the history by means of recorded old information. The Meditix system that's used. Traceability. Having error in traceability is usually due to human error. For example, here you have black parents with a white baby. We know that's a bit impossible to have unless there is an error. And as well as a pregnant woman, she knew that she was implanted with basically a different sperm than her husband's. That's a bit of a shock. Witness system is monitoring and recording all activities of workstations where samples are moved from one dish to another all year round. Quality control in IVF lab. There are some quality controls that has to be done on a daily basis in a lab, such as incubators, CO2, temperature, oxygen, and pH. For the temperature of refrigerators, it needs to be between 2 and 8 Celsius. For warming plates, it needs to be 35 degrees plus or minus. And the temperature and humidity of embryology and andrology lab has to be between 20 to 25 degrees. Storeroom and cryopreservation room has to be between 18 to 22 Celsius. Humidity has to be between 30 and 60 degrees at all times. Continuing with the quality control in the lab, we have the paperless lab. Add an effective electronic data record, virtual record basically, to keep daily records, audits, fluctuation reports such as reflection up. Alarm system. All lab parameters have to be surrounded with independent sensors, such as log and guard system and OSHA view system. If you have any, what's it called? Like you have a different percentage of humidity, let's say, in a lab, then the sensor will goes on to let you know that there's something that has to be fixed. As illustrated here, this is for the temperature and the bench control. We have the liquid nitrogen preservation tanks and the humidity monitors. External lab inspection. I'm very sure all of you are very aware with these, such as CAP, ISO, ISHRI, and human fertility and embryology. Continuing with internal and external quality control, it is an educational tool that allows patients to have, participants to have, monitor, evaluate, improve their performance, improve both national and local standards, provide educational system, internal and external, as well as check the efficiency of internal quality control procedures for embryologists by monthly performance or yearly audits. For external quality control, embryologists will receive andrology and embryology slides and tests online, ensure that the results are reliable and comparable. To summarize everything, constant monitoring of products, constant monitoring of lab conditions, benchmarking, troubleshooting with any problem, validation of equipment, planned preventive maintenance, Manual of all equipment, log faults, services technician and technician contact number, calibration of external measures equipment, annual maintenance, contacts of equipment and filters with the supplier company, daily control of temperature and CO2 and pH. Especially the last point, it's very important to be checked every day. Stable culture condition. Lastly, but not least, best practice depends on an effective quality framework. Quality must be inherent in every aspect of an organization. For executive management to the lab workers, quality must be integral. It cannot be an add-on. Quality is everyone's business, not just the quality managers, and it must be led from the top. The four foundations of quality in lab IVF are clean and healthy environment, sophisticated and well-maintained equipment, IVF tested disposables and supplies, and technical skills. Thank you very much.
Thank you, Dr. Anfal. We will now move on to our first oral presentation for this session. I would like to call upon the stage Dr. Ruqayya Abu Rawi. She's a senior embryologist for Noor al-Hayat Fertility Clinic. She'll be talking about in vitro fertilization outcomes in ICSI, cycles using different methods of human sperm preparation, determine the less stressful technique.
السلام عليكم ورحمة الله. في البداية سعيدة جدا بوجودي هنا for a first time as a speaker. في الليلة الماضية الدكتور محمد محاشي قال وراء كل رجل عظيم امرأة. اليوم حبيت شوية نغير في المقولة ونقول بجانب كل امرأة ناجحة رجل عظيم. حبيت في البداية نشكر داعمي ومعلمي في هذا الفيلد زوجي باشمهندس عبد العزيز بالحاج. كذلك نشكر زميلاتي في المعمل وكل كادر نور الحياة وكل من ساهم في نجاح هذا المؤتمر، وأهلا وسهلا بضيوفنا الكرام. My topic today, I will talking about in vitro fertilization outcomes in egg cycles after human sperm preparation by different methods, and which one less stressful. Okay. What's the aim of the semen sample preparation? The need of embryologists to obtain normal motile sperm has led to the development of the many methods that separate healthy sperm in morphology and motility from the rest of the semen sample. And the most important of this method are sample washing, direct swim up, and discontinuous density gradient. First method is the swim up. It's began by washing a semen sample, then placed the sediment under the media at the angle 45 degrees in conical tube for 10 to 16 minutes. The idea is that the most active sperm will swim up, single from the rest of the semen component. Second method is the density gradient. In this method, centrifuge the semen over density gradient, which separates cells by their density alone. Two-density gradient layer preparation method is the most widely applied. Sperm preparation using this density gradient centrifugation usually result in a fraction of highly motile spermatozoa free from debris, contaminating leukocyte non-germ cells, and degenerating germ cells. Third method with us here is direct sperm migration in injection dish. For this protocol, semen sample directly used in the EXI dish by creating a line from the manipulation media and PVB. In the end of this line from the manipulation media side, the drop of the semen is placed according to the concentration and motility of the sperm. Here we have some studies talking about same topic. In this study that published in 2020, they compared between micro swim up and minimally conventional swim up. The results showed that the timing procedure were significantly different between both groups, and no significant difference in the pregnancy rate between both groups. Another study that published in 2017, the results showed that the fertilization rate were not significant different between density gradient and micro swim up, while significant difference were found in the blastulation rate. Okay. Another study that published in 2022, the results showed sperm preparation using density gradient and swim up separately resulted in a similar IVF and ICSI outcomes. Fertilization rate, good quality embryo, and blastocyst formation rate were similar between the groups. In this study, we compared the separation by density gradient, swim up, and direct sperm migration in EXI dish. This comparison was made in 3 groups. First group, normal semen analysis. We have 950 cases. The second group is oligoasthenospermia. We have 1,300 cases, and severe oligoasthenospermia, 900 cases. We compared the fertilization rate, grade A embryo, and pregnancy rate. From the female side, we include just a good response cases, and we exclude the PCO cases. Our result, in the first group, normal semen analysis, there is a significant difference in the fertilization rate, grade A embryo, and pregnancy rate between direct sperm migration in injection dish and other method. In the second group, oligoasthenospermia, there is no significant difference in the fertilization rate and grade A embryo between all methods. As for pregnancy rate, there is a significant difference between the direct sperm migration in injection dish and other method. As for third group, severe oligoasthenospermia, there was no significant difference in the fertilization rate, grade A embryo, and pregnancy rate between 3 methods. Here we have charts that describe the result. As we can see, in the first group, normal semen analysis, there is a significant different fertilization rate between direct migration in injection dish and other method. Also in the grade A embryo and pregnancy rate, compared between other methods. Our result greatly support to prepare EXI samples by direct sperm migration in injection dish to reduce time, reduce cost of another method for preparation, reduce stresses on the sperm, and increase the pregnancy rate. Thank you.
Thank you, Dr. Ruqayya. Moving on, we'd like to move to our second oral presentation for today. It will be given by Dr. Fatima Al-Sharif. She's also an embryologist with Noor Al-Hayah Fertility Clinic team. Her topic will be about fresh ejaculation or ejaculate versus fresh testicular biopsy in severe oligoasthenospermia teratozospermia, cases subjected to intracycloplasmic sperm injection trial.
Good afternoon, everyone. Today I want to talk about fresh ejaculate versus fresh FNA in severe oligoacinoteratozospermia cases during exit trials. As we know, the intracytoplasm sperm injection is one of the most assisted reproductive techniques that use it for a variety of tests that related to fertility problems. The journey of the XZ include two partners. Both of them can depict the progress of the XZ through many factors. Later, my colleague, Dr. Amira Frewan, will explain the one of the female attributed factor. But now, in this study, we investigate another approach which is related to the male partner. The male partner can affect by many factors, including of these factors are the mans with severe oligoacinoteratozospermia. The semen sample for these cases include very low values, very low count, less than 1 million per milli, very low normal form, less than 1%, and very low motility. The progressive motility is equal to 2. These seeming criteria has led to failure of numerous of XZ cycles. There are previous studies that indicate the extraction of the sperm from testicular biopsy is preferred for this type of cases than use the sperm from fresh semen sample. In our study, we discuss and compare the embryo quality, fertilization rate, and pregnancy rate between the fresh sample and testicular biopsy. In our study, in our research, we study 48 cases of the patient with severe oligoacinoteratozospermia, and we divided them into two groups. The first group has 24 cases injected by the sperm from fresh sample by masturbation method. And the other group has 24 cases injected by the sperm from testicular biopsy by fine needle aspiration FNA method. Now I would like to give you an overview of the criteria that we following in our data. All cases underwent exit trials in الحياة Fertility Center, and the ages of all cases between 25-39 years, and the all female has the same criteria and same endometrium parameters. After studying the cases and the data of the cases, we came to the following result. The first comparison about fertilization rate, we shown in testicular biopsy with 52%, but in fresh semen sample with 48% with non-significant result. The second comparison about grade A embryo, we shown in testicular biopsy with 43%, but in fresh semen sample with 40%, also with non-significant result. The last one is about pregnancy rate. We shown higher in testicular biopsy with 28% and lower in fresh semen sample with 16%. In our conclusion, despite for the percentage of the result grade A embryo, the other of the two parameters of fertilization and pregnancy rate were lower in fresh ejaculate group than in testicular biopsy group. However, the difference in the three parameters result between the two groups of fresh ejaculate and testicular biopsy were not significant different from each other. It can't be confirmed whether fertilization rate, quality of embryo, or pregnancy rate are related to the method of semen sample collection. Further investigation using large sample size would be more informed and reliable. Finally, I would like to thank our lab indicator, Dr. Abdelaziz, and our laboratory team to the good job and good result. And I'm grateful for الحياة Fertility Center to give me this chance. Thank you for your listening.
Thank you, Dr. Fatima. Moving on to our final oral speech for today's session, I would like to welcome to the stage Dr. Amira Frewan. She's an embryologist also at الحياة Fertility Clinic. She will be talking about the effective denduation timing in intracytoplasmic sperm injection trials on the cytoplasmic maturity of oocytes.
Good afternoon. Okay. Good afternoon. In the beginning, and on behalf of myself and my colleagues, I would like to welcome you in الحياة First Fertility Conference. Actually, it's an honor to be standing in front of such an audience. Now, today I will present for you, one of our studies, which was about the effect of denudation timing in exit trials on the process of cytoplasmic maturation of oocytes. Okay, okay. According to the National Center for Biotechnology Information, ICSI succeed in 70 to 80% of cases, resulting in fertilized oocytes. However, complete and partial fertilization ratio are still of a big concern in embryology world. Actually, total fertilization failure have been encountered in 1 to 3% of all ICSI cycles. As mentioned earlier by my colleague Fatima Sharif, actually the ICSI procedure is a crucial procedure which involves two partners. Both partners can affect ICSI through several factors. Now, Engineer Fatima had illustrated one of the male-attributed factors that represent a serious issue in many ICSI cycles. Now, I will present another approach investigated in our laboratory, which is about the female partner contribution to such an issue. Now, among the numerous female-attributed factors that are of a big concern in embryology is the controversial matter of oocyte maturation. Oocyte maturation, as I said before, is a crucial procedure, and it's obvious that any oocyte must be mature to be fertilized. In ICSI preparation, oocyte maturation is an essential requirement. So any lack in the evaluation of oocyte maturation and the injection of such compromised oocytes can result in reduced potential of in vitro produced embryos. Actually, oocyte maturation involves two separate stages: nuclear maturation and cytoplasmic maturation, which are asynchronous processes. Now, the process of nuclear maturation and cytoplasmic maturation are normally coordinated through this mechanism requires the emptying of the germinal fissile contents with the cytoplasm at the stage of germinal fissile breakdown. So, the cytoplasmic maturation might be compromised in the process with, compromised if it's not synchronous with the nuclear maturation and if it's not normally coordinated. The modification in the localization and morphology and the biochemical properties of cell organelles must occur for the oocyte in order to acquire sufficient competence to be fertilized and also for subsequent embryo development. Now, the process of ovarian stimulation has been suggested to disturb this localization, which might actually affect the oocyte maturation. Nuclear maturation is clearly visible under the microscope. Simply, the lack of the germinal fissile and the presence of the first polar body are the most obvious characteristics of oocyte maturation. So we can say that this oocyte is nuclearly mature. However, in spite of the appearance of oocyte and in spite of the presence of the first polar body, the oocyte cannot be considered to be truly mature unless the cytoplasmic maturation is complete. So nuclear maturation without cytoplasmic maturation will actually lead to no way. This study intended to explore the influence of oocytes pre-incubation, barrier to denudation, on the maturation progress. Now, the pre-incubation may induce the completion of cytoplasmic maturation by just offering suitable conditions for the oocytes while still surrounded by the corona cells, which might actually eventually improve the EXI outcomes. Now, can we actually enhance the maturation process and empower the cytoplasmic maturation by just delaying the denudation stage? Can we actually make use of the surrounding corona to permit the completion of cytoplasmic maturation, resulting in more oocytes that are fully mature? In order to answer such questions, we have examined 52 consecutive EXI cycles divided into two groups. The oocytes of the first group were denuded directly after retrieval without incubation, while the oocytes of the other group were subjected to cumulus corona cell removal after a period of 2 hours of incubation. Our results were the most simple. The maturation rate of the first group, in which oocytes have been immediately denuded, was actually 63%. A value that's much lower than the maturation rate of the other group, in which oocytes have been pre-incubated before denudation. Here, the maturation rate was 77%. Furthermore, and upon statistical analysis, we found that our results are having actually a p-value of 0.008, much less than 0.05, which indicates that our results are actually significant. So we can say that the maturation rate of the immediately denuded oocytes in the first group were significantly lower than the maturation rate of the pre-incubated oocytes. Now, this result confirms the assumption that actually delaying the denudation time may have a positive impact on the cytoplasmic maturation. So it's recommended to adopt this technique of oocyte pre-incubation in embryology laboratory in order to accelerate the maturation process and also to have more injectable oocytes in each EXI cycle. Now, it's of practical value to just design more clinical trials in order to have more significant results that can be that by just increasing the sample size, also to examine the time variable and to determine the ideal denudation timing. Thank you for attention. I'd like to thank our team in the laboratory. The girls were awesome. I'd like to thank Dr. Abdelaziz. Thank you very much.
Thank you, Dr. Amira. That brings us to the end of our presentations for today. We'd like to open the floor for any further discussions or questions. The panel of chairmen will be guiding us through this.
Yeah, thank you very much for these nice presentations. The floor is now open for discussion. Any questions? Yes, please.
Talks from نور الحياة للخصوبة are the best indicator for the lab quality. Thanks, Abdelaziz.
Dr. Mohammed.
والله هو مش وقت أسئلة ولا تعليق لأن كلكم بتناموا. Anyway, I want to concentrate on انتصار. Are you still embryologist or moved to the clinician? Huh? You are an embryologist because your talk was mainly clinician and a clinical side. So, about the endometrium, about the progesterone window, about the return later. So you talk, it is to the clinical, unless you take in your lab all freeze. You are doing all freezing? No.
Can you just
Yes.
take the microphone, please, for the answer?
You combined between freeze all depending on the clinical needs. In the cases that I mentioned that in case of pre-implantation genetic testing in day 5 or day 6, we have to freeze all. But still we are doing combined between fresh ETs and frozen ET. But more than 90% of our cases freeze all for all.
That's good. So you are in the normal way. Usually we freeze not polycystic, but hyperstimulation syndrome when out of control. This is usual. Or due to social problems, they can transfer. Or due to something happen clinically. Okay, so, but you are, means you are with freeze all. And that's from your lecture. And you went to some clinical because it take a long time. Your daughter is excellent. Excellent lecture. And I want to ask for the last speaker, last speaker about the donation, immediate donation. So, done a study for a long time, about 15 years ago, in our center. And we find no difference. Maybe leave it after 2 hours or 3 hours, even 4 hours, and no difference. Mind you, if you have some blood, then you have to do the donation immediately. Otherwise, no need to extend your study. And thank you.
Yep.
Okay, thank you. Dr. Amfel, I'd like to thank you about your excellent presentation. And I want to add something, is that every IVF center should have a quality control team. And this team is composed of one of the lab member and a nurse and a managerian who is its function and his job committed to ensure that all quality control steps may be applied at the IVF lab. And thank you very much. A very, very good lecture, and I really enjoyed it very much. Dr. Amira, thank you for your lecture. I want to ask you, please, what is the incubation period you use in your presentation? Okay? You incubate the oocyte for how many minutes in your study? Thank you very much, and also it is a very, very nice lecture. Thank you.
Thank you, doctor. Actually, our incubation period was 2 hours, but we are looking forward to design another studies so we can actually determine the ideal denudation timing. We might incubate it for less time. Thank you very much, doctor.
Are there any more questions? Yeah, Professor van der Horst.
Thank you for the very nice presentations. I assume you do all these wonderful quality controls. What's your quality control for the sperm evaluation?
Yep.
Actually, in our lab, as my daughter mentioned, that we have internal and external quality control. Internal quality control, we are doing every 3 months the same sample. All of the staff has to go, has to do semen analysis for the same sample, and we will see the variation. And every year we do CAB test, and we have to receive some slides and online test, and we have to send our results to the CAB, and we will compare every each embryologist in the lab if it's met the yes.
Very good, excellent. Sorry, perhaps just to add to that also, do you store your slides for vitality, morphology, for feedback, and also do you do videotaping? I don't mean you have CASA. Let's say you don't have CASA. Do you keep video records so that you can go back to that and
Actually,
do quality control on that?
we don't save the videos, but we save like for 3 months. After 3 months, we'll discard the old ones, and if the patient come back, and still we have to do a new vitality test, a new morphology test, and to compare the previous one and the current one.
Good to hear you do quality control.
May I just ask the question as well with regard to quality control? Is that also internal for individual technologists, that they are doing repeated measurements and comparisons, and within different individuals, so that overall the result is comparable and the same?
Audit. We have to invite someone from abroad, has to come in our lab and spend 1 day, sometimes 2 days, to see our performance, to check our data, our documentation. He has to stay with every single embryologist to see how the workflow, how from the once we receive the sample till sample preparation, OBUs and quality control and XC injection, embryo transfer, freezing, every single thing. And after 1 month, he will send us the report, and we will see if we met the requirement needs and so far we are CAB accredited and GCIA accredited as well. Yeah.
Thank you very much. Any more questions? Yes.
Our late Professor Raja Mansour committed a society called Quality and Registry Control for the IVF lab. If you allow me, I can stimulate you to do such commitment all around Libya.
Thank you very much. Just behind you. Any more questions? Yes.
I want to ask Intisar, how much it costs your cycle in Dubai, in Abu Dhabi? How much it costs? Each cycle, how much it costs? XC trial. In your center, how much it costs?
For the local, they are very lucky, because it's fully paid by the government from A to Z. Zero payment. But in our center, we do our center unlimited, unless embryo transfer is not done, unlimited. But if embryo transfer done, they are calculating only 3 embryo transfer per year. If I said that if on the other hand, the cash payment, we have packages. We are offering the cash payment packages, like if the patient will go through this package from the first visit. I will not mention the prices because it's a kind of confidential. No, it's confidentiality, and I respect our lab, our clinic confidentiality. But we have very good offers for those can afford. The owner of the center, he will volunteer like $1 million dollar for those are like limited salary, for those for are cannot afford even buy single injection for free from A to Z. But they have to meet the requirement that they cannot afford and they cannot pay for the cycle. Yeah.
Thank you very much. If there's no more question, then there's one question there still.
Hello, everyone. Just have a little bit small comment about Professor Mohammed Al-Mheshi comment. First thing I learned from Professor Hassan Maghrabi, my teacher, in the labs, especially in the labs, I can't stop my thinking and my testing. Everything depends on paper or something published before. So we should try everything, and we should examine everything. Even that things that we thought it's fixed and we can't change it, like denudation time. Actually, we are washing the oocyte from the blood, so it's clear out of blood and separated from blood, and we put it inside media without denudation, and we incubate it inside the incubators for 2 hours, and we have a great result with this method. So I saw a lot of papers that published in different method, like immediately denudation or something like that. But in my lab, in my own lab, I saw this is very nice method, and I have quite good pregnancy rate with this method. So I think we should examine everything, and even the things that we thought it's fixed and we can't change it. Thank you so much.
Yeah, thank you very much for these lively discussions, and also thank you very much for the presentations that were really great value and give us all a good hand. Thank you very much. And with this, I close the session.
Thank you, doctors. This brings us to the end of our second day. We hope to meet you tomorrow, inshallah.